Hello everyone and welcome to today's webinar session, which is called Lenstar Myopia in a Busy Practice. We have two presenters today, Dr. Michael Bärtschi, who is the owner of INES, Wellness for Your Eyes, the leading contact lenses and optometry practice in Switzerland. Dr. Bärtschi has a Master of Medical Education from the University of Bern, a master's degree in clinical optometry from the Pennsylvania College of Optometry, and he also holds a PhD degree in biomedicine. He's an adjunct faculty member of the New England College of Optometry in Boston, and he also is currently a fellow of the American Academy of Optometry and European Academy of Optometry. Michael Wyss obtained his Masters of Science in Vision Science and Business from New England College of Optometry in the United States. Also, he is a fellow of the American Academy of Optometry and a current adjunct faculty member of the New England College of Optometry in Boston. He's a member of the executive board and board of directors of INES. With this, I would like to welcome you to today's webinar, and we start the webinar now.
Good morning and welcome from Switzerland. Together with my colleague Michael Wyss, I would like to present to you the reasons why we use Lenstar Myopia and the iSuite software in our busy practice. While we are paid consultants for Haag-Streit in Switzerland, however, the following impressions reflects our own decision-making process and experiences made by our entire INES team, unaffected from Haag-Streit, and is the independent manifestation of Michael Wyss and myself experience. What were the requirements to choose the Lenstar Myopia? It was accuracy that we needed, efficacy, the comfort and safety, affordability, the clinical benefit, style and space, the profit, and also the prestige of such an instrument. For us, it was also very important to have a smooth integration into our existing clinical procedure. The Lenstar Myopia biometer is now the backbone of our myopia management. About the clinical evidence of axial lens, you heard already the talk from Dr. Fo Lian, and we all know how important it is now. There are enough evidence out there regarding regular axial length indices, not only for sex-related incidents like female or male, but also for Caucasian and Asian eyes. I like this graph from the Brian Holden Vision Institute because it's also the legal law that we have to diagnose myopia by refractive error. It has to be clear that this eye is a myopic eye or not. But after this decision, after the diagnosis, we have to monitor the progression of the myopia or the success of our myopia management interventions by axial length. And this can be done with an optical biometer like the one from Lenstar. We are not the only one that have decided like this. Also Dr. Kate Givert, well-known myopia expert, she also stated that the axial lens has well been established in the clinical and critical measurement in examining the progression and control of myopia in a research setting, but also in a practice like our practices. It is much more sensitive to detect myopia progression than refraction, and axial length also appears to be the key risk factor for lifelong myopia pathology. It's doing this, it's much more so than refraction. There are 6 reasons why we as an INS team have chosen the Lenstar Myopia.
Let's talk about our first reason, accuracy and efficacy. The precise axial measurement of the entire eye from the cornea to the retina is key and well known from the Lenstar 900 and its accuracy for refractive surgery. And you know, for refractive surgery, the precise measurements are key when you implant an IOL into the eye. So it's the same instrument, it's the same device, just the software is different with the Lenstar Myopia. With the fast automatic positioning system APS, performing the axial length measurement is easier than ever. The APS tracks the patient's eye, and with one click, the 8 measurements, 4 per eye, are taken in under 1 minute. APS also improves the repeatability of measurements. Our second reason was comfort and safety. For us, it was important that we have a device available which is absolutely useful with kids. So it must be safe and they don't get harmed somehow by bright light, for example. And it should be comfortable as well. So here's a video of the capturing mode. As soon as you are in the green field there, the device itself starts moving by magic hands. So you don't have to touch anything. It just automatically go to the right position and do the measurements. If there is a blinking, it stops the measurements. And here you see we are on the first measurement, the second, and now the third measurement, and the last one is done now. So it's very, very fast. It only took about 28 seconds for those 4 measurements. Now we are approaching the most important point, the clinical benefit. If you buy a device, you want to have a benefit in your clinic out of it. So if you take a look at the Lenstar Myopia, we have to talk about the really outstanding software. I would like to show you with an example of Luana, a patient of mine, how these refraction charts working. So let's go through it. In the beginning, Luana came in 2009 with a little bit of myopia, but 2 years later, she reached already -3. So she is a fast progressor. And if you don't do anything, she will progress up to -8 10 years later. So that was the point where we discussed with the parents together what we're going to do. In this software, you get these lines provided, showing up all the different treatments available. So like defocus contact lenses, defocus glasses, ortho-K, atropine. And you can add other treatments you would like to do, like PAL, for example, PAL glasses, or whatever you like. So it's open. The software, you can customize it and use your treatments you like to do. So go back to Luana, 2012, we started with defocus contact lenses and we had an effect. So the first year we have stopped the progression, but in the second year it again increases the myopia progression, and finally we came to the same point if we did nothing 2 years earlier. So we decided then to step over to orthokeratology and started with the treatment here. So you see the myopia drops down and was very stable the next 6 to 7 years. In the age of 18, Luana decided to stop ortho-K and wanted to have just normal regular contact lenses and see what happens. It increases again the myopia. We still in the discussion with her to start again with ortho-K, so we will see how the biometry is looking like. So the axial length is the critical point and not really the refraction. So that's the next slide. So here we are. This is the axial length of Luana. at the beginning, 2009, we didn't have the availability of measuring the axial length. We only had it from 2014. So that's what's the point where we start with ortho-K. And you see during ortho-K, we didn't have any axial length progression. But afterwards, after we stopped ortho-K in 2019, she progressed again in axial length. So that's really nice about that chart in the discussion with the patient to show what's happening to the eye, that it starts growing again and we do have to do anything. So the question now is, why was that the case in Luana? And so that's the next chart, which is very interesting to look at. Here you see now the chart concentrating on the environments of this specific patient. So first of all, you have the parents. Are there two parents myope or one or no, none of them? The age of the onset of the myopia, how much near work she's doing and how much time she spent outdoors. And you see here how it changed from 2009 to nowadays. She's now in university and studying a lot. So you see she's spending much more time indoors, reading much more, and that's not a good point. So she should go outdoors, and that's probably the reason why she increases her myopia even in the age of 20 years or older. Another very nice thing about this software is that this progression can be manipulated by yourself. So this is an example of another patient of mine. It's my son, and he started myopia a little bit 2019 and had some increasing myopia till to date. But you see the software calculated from that point on that normally an European boy will progress that way if you don't do any treatment. But Liam, he was not having any therapy, and he progressed way slower than which would be accepted. So now the good thing about that is that you can adjust with a few clicks these curves and get the real progression showing up in this chart. So now we are by minus 2.6 diopters in about 10 years and not minus 4.4 diopters like the software said before. So it's really powerful, and it's also good to have real data available, and the forecast of the progression is really what your patient is doing and not something like some other patients in Europe or Asia are expected to do. And here's another very interesting approach where the software of the Lenstar Myopia is very helpful. This is my younger son, even, and so he has at the moment hyperopia of plus 0.75 and a plus 0.25, which sounds good. He's in the age of 8. But if you look at the length of the eye, you see he has a 25 millimeter long eye, which is quite long for a hyperopic person. So if we have a look on the forecast of his myopia, we see now, even if he is in a hyperopic mode at the moment, but the forecast is by -4 in 10 years. So this chart also gives you a powerful tool in the discussion, in the communication with the parents. Before the Lenstar Myopia, I probably would say your son is perfectly right, a little bit hyperopic, nothing to worry, probably no myopia in the next few years. which is totally wrong when we look at this chart here. So it's an evidence-based myopia forecast even before onset. So in this case, it's very important that to strongly say that go outside, don't read too much, is absolutely necessary for that child here. And our last point now, and it's a very interesting point, is the dilated fundus examination. Sometimes it's hard to decide if it's really necessary to dilate pupil. If you have a patient like this with -12 diopters, it should be clear you have to dilate your patient. But if you're not really sure, you can have a look at the eye length, the axial length of the eye. In this example, we have 29 millimeter axial length. So that makes it absolutely clear you have to dilate such a patient to be really sure that you don't have any problems, pathological problems like some breaks in the retina or detachment formation. So let's have a look on the pictures here. So this patient came in without any signs of sinus and floaters, just for a regular exam, but because she has a very long eye, we decided to make a fundus examination, a dilated fundus examination, and it came out that she already had a detachment progressing. So it's just one additional point to show how important it is to know the axial length in a person's eye. After all these positive things, you have to talk about a pitfall with contact lenses. So if you have a child with myopia management and contact lenses, it's perhaps an idea to just make a measurement with the Lenstar over the contact lens, but that will create a failure because of the thickness of the contact lens. So here's the details. You can go into this software of the Lenstar and see the details of the measurement. So you see the first point should be the cornea anterior epithelium, and it measures the axial length just to the back of the retina. So now if we take a close look on the cornea section, it appears that you have two peaks here. The first peak is the contact lens in front of the cornea, and then you see the second peak is the epithelium of the cornea, and the last one is the endothelium as the end of the cornea thickness. So in this case, we have a measurement of the corneal thickness of about 590 microns. So let's have a close look. If you take just a measurement of the epithelium to the endothelium, the cornea is only 520 microns thick. That's a pachymetry measurement, which we normally have. So with the contact lens in place, we have 70 microns more axial length measurement just because of the contact lens. So that means in total we don't have a axial length of 25 millimeters and 150 microns. We only have 25.08 millimeters. So it's a small difference, but if you don't do that calculation, you probably have an increasing axial length when you use MiSight or other contact lenses, and that would be wrong. So that's just a small pitfall, which is important that you know it can happen. So let's switch gears. Now we're coming to another reason for this instrument. It's affordability and profit. The Lenstar Myopia is somehow reduced to the max. So you have a fast and accurate biometry measurement and an excellent analysis software. Nothing more. That's it. That's what you need for a myopia management. And so you get the price down when you need that instrument. Additionally, the APS system is helping your medical assistant in the fine alignment of the device. So it really allows you to delegate the biometry to your staff, and it allows a really efficient flow in your busy practice. And finally, the next few slides I will show you the customized report, which can be print out from the software from the Lenstar Myopia. It's a really efficient decision-making tool. It's simple and it's understandable for the parents and also for the kids. So let's have a look. So here's the customized report. On the first page, you have all these data, the eye lengths, diopters, refraction. And on the next page, there is the forecast, the myopia forecast, where you think the child will be or the patient will be in about 10 years time, and the chosen treatment, what is be the aim or the goal of the treatment, where we should end in a few years. Also the axial length progression report, you see how the child's eye was growing. The third page, the next two pages are about additional information. It's more like a general information. What is the risk ratio in that myopia development? What is the risk for, let's say, a retinal detachment when you have a myopia of -5 or higher? It's talking about go out into the sun, playing outdoors for kids, preventing the development of myopia, avoid near stress when you read too much. So it's more like a general information, but it's really handy for the patients. And most importantly, at the end, you have your active treatment at the moment. Like here, as an example, the defocus glasses from with a DIMS technology from Hoya, but it could be whatever treatment you've chosen. It's just the final sentence is what you are doing the next few months with the kid and the parents together.
The fifth reason was style and space. The Lenstar Myopia is small. It can be fully integrated into your existing infrastructure, and it's fully automated. It has a clinical style appearance. It is noise-free and it's extremely kids-friendly. And of course, the sixth reason is prestige. Haag-Streit is a typical Swiss company. Maybe not always the quickest company in developing something, but if they develop something, it is 100% competent and the Swiss quality is included. So the take-home message is that the Lenstar Myopia is an essential, precise, safe, quick and easy, informative, stylish and profitable instrument for the modern myopia management practice. Thank you so much for listening and thank you for serving our kids.
Thank you very much for this talk, first of all. The first question would be, from your experience and your daily routine, what is the minimum age of myopia patients you can measure with the Lenstar Myopia?
Okay, so we had, so far our youngest patient was 8 years old. I don't know if it could be younger than that, but that was nearly no problem with at all. But it depends highly on the patient. Some patients in that, some childs are more difficult. The good thing is with the Lenstar Myopia, you don't have any bright light. And so it's not so difficult for the kids to really have a good measurement there. But it depends, of course. Some 11 years old childs are more problematic than 8 years and the other way around. So it depends on the child.
Yeah, of course. Thank you very much. There's another question. Usually we advise kids to wear sunglasses to stop UV damage. How does this affect myopia progression if the child wears the sunglasses all the time for 15 hours outdoor activity per week?
Okay, if a child is outdoor for 15 hours per day, that's quite a lot. So maybe it was more 15 hours per week than per day. But anyway, it's a very good question that is in science, we don't know exactly at the moment. On one hand, we say that they should go outdoor for sunlight, but on the other hand, we are trying to avoid them from any harmful rays. So there is no final answer to this question. In Australia, people or children should wear hats and also glasses, but this will avoid a lot of light from the eye and for the development of the eye. So I would say 1 or 2 hours per day outside without sunglasses should be okay. But if your child is playing a lot of sports outside, then sunglasses will be a nice thing.
Mm-hmm. Thank you very much. Another question, how does the iSuite Myopia software integrate into your IT environment? Do you perform the measurements and the discussions with the parents on the same PC, or do you split it up? How do you do it?
So as you see in my background, this way, you see my finger. So in my on this one. Oh yeah, in the back you see the Lenstar. So there's the whole measurement line. We have several measurements or several instruments you see here, and that's only for the measurement. So we just make the measurements there, and then we go in our separated rooms. We have 4 optometry rooms, and so the discussion will be there. So all the data is going into a server and is held there, and we just grab this from the software, the data there on the server, and just place it wherever you are. You could take it at home if you like. So it's what I would say for Haag-Streit, all the instruments are really easy to integrate in a server platform. So it's really not a problem with a Lenstar or perimeter or whatever.
And it's usually, and of course, better if you can talk and discuss this issue together with the parents in a room like this. And I'm sitting here in one of our exam rooms, and okay, you can see maybe that there is the software on the computer, so we can sit together in the eye exam room and discuss together with the parents what's going on.
Thank you very much to both of you. Another question, are you suggesting that an axis length measurement on even asymptomatic child to be performed on a routine basis?
We do. It depends how your practice setup is, but we think it's best to have by the first contact, you should have all the measurements. So if somebody is coming for the first appointment to our clinic or our practice, we do all the measurements, biometry, also a fundus exam, a wide field fundus image, just to be sure whatever happens in the future that we do have some starting point and can compare in the future. So I would highly recommend to do it on every people, on every child, perhaps not every half year, perhaps, but the starting point at the first appointment, I think it is a good point. And then depending on the race, on age, probably you have to do that more often.
Thank you very much. I think you mentioned it in your presentation already, but the question is still there. How is the myopia report perceived by the parents?
So you can send it by email as a PDF if you like, but I more like to print it out and hand it over to the patient or the parents, but it's up to you. You can choose. The good thing about that report is it's really the data of their child. It's not something it could be, or we know that all the European boys and girls progress like this. It's really the child's data, and that's really so powerful in the discussion and the decision making.
Yeah, Thank you very much. Regarding this, I think this is also a nice question. Is it possible to explain more of how you adjust the progression forecast? Is the one you mentioned quickly, that it's so nice that you can manipulate it?
So I don't know if you have to go back somehow, or let's see if I can.
If you can take over the screen, otherwise I can just.
Let me. No, I can't.
Let me quickly see if I can find this location. I think here.
Yeah, I can show it here now. So yes. you see on the right is progression. It's a bar with a blue dot. And you can just move it to the left. It will increase the progression rate, so it's higher than expected. Or you can go to the right, which is making it very, it's as a slow progression. So it's on that bar, and you can just move back and forward and see if it fits then. I don't know if that clears up the question.
And let us see if we receive another one regarding this topic. Would you see a benefit of having additional parameters like the central cornea thickness or the pupil diameter or even other parameters during your myopia sessions?
I mean, these data are provided by the Lenstar, if you like. So it's in the setting. At the beginning, we start with all these measurements, but then you have a bright light. And we shortly make the experience that the kids don't like it. And for me, for myopia management, it doesn't really matter that much. I do have other ways like the Takehome in my office or topographer, where I see the pupil diameter. Pupil diameter can be important if you work with orthokeratology, for example. But for me, on that device, it's more important to have a good measurement of the eye length. And if I just mix it up because of the bright light, I just take it away. But it's there. It's in the software. You can use it if you want. If the child is older than, let's say, 10 years old, I shouldn't think there's a big problem. But if it's younger than 10, I wouldn't take it. So I think it's better to just, choose another way or make it the next day or the next appointment, these measurements of the pupil.
This may be also important because you see so many instruments in the background of Michael Wyss, and of course you cannot do all the instruments with every child in one session. Sometimes you have to decide what is the very important ones we need now exactly, and what can we do maybe next or another session a little bit later.
Thank you very much. Regarding this also, what do you think about combination therapies using atropine and orthokeratology at the same time, for example?
Absolutely. Absolutely. There's no reason not to do it.
Yeah. Okay, thank you. You mentioned that you have to dilate the patient's eye when you brought up the example with the patient who had -12, I think it was -12 diopters. Could you provide a rule of thumb when you think about dilating?
Not by diopters. Now I would say let's have a look on the eye lengths. And if you have let's say more than 26 millimeters, you have to have a look somehow on the peripheral retina. If you can dilate. If you have an instrument like we have for a wide field measurement, use that instrument. But you have to, and if you can't do that, refer to an ophthalmologist. So the eye length is really critical. I mean, I do have patients with normal eye lengths, and they did have some tears in the periphery. So it's not really 100% safety thing, but as longer as the eye is, the higher risk is for have some retina problems.
Thank you very much. Regarding this, there just came a question in. If you are doing combination therapy, how do you use the prediction chart? Are there prediction charts for combination therapies?
It's not there right now, but as I said in my talk, that it's open. So the software is open. You can add whatever future therapy is coming up. And so if it is combination therapy, the data now is coming up how efficient it is. It can be more like 80% reduction of the progression rate. So you could add atropine combination with ortho-K or whatever you like. So that's the good thing about that instrument. It's not like you buy something, it's up to date now, and a half year later, all the things are outdated, because myopia management is so fast in all these studies coming out at the moment. So it's really important that these therapy modes are open and you can change it whatever you like.
Mm-hmm. Actually, the combination therapy most of the time is 0.01% of atropine with something else, usually, let's say, with orthokeratology. But as we can see, how much better that higher dosage would work with atropine, we can very well expect to see combination therapies in any kind. So combinations with eyeglasses and atropine together with ortho-K and atropine. Everything is possible, and that's the good thing, as Michael said already, that you can individualize the therapy and also the expected results. So you can really do it individually. That's a great thing.
Mm-hmm. Thank you very much. There's also another question about treatment methods. What do you think about, I think you mentioned it also shortly, about the new spectacle from Hoyer, the MyoSmart. Did you have the chance already to use it?
Yes. Yes.
Yeah.
And the question is?
what do you think about it? Excuse me. Sorry.
Okay. Yeah, it's a little bit short to say something about the effectiveness of this therapy. But what I can say now, after the first month we have that glass now and selling it, that it needs some adaptation time, especially if you have a child already wear a single vision glass. It's only a small
aperture.
Sorry?
Aperture.
Yeah, small aperture where you really see sharp. So the child needs to turn the head more frequently, and but after, let's say, a week to 10 days, all of our kids so far adapted to the glasses. But I'm sure if somebody is too critical on that, it could be a point where they say no, thank you, and change to another option. The good thing is that we do have several options now for myopia management. It's from glasses, contact lenses, atropine. It's great. And so it's just our job now is to choose the best therapy for that child.
Mm-hmm. And I'm quite sure that it will change over time, as Michael said. Maybe you start with a very young child with atropine, that could be, and then you add maybe also a glass like the MyoSmart, and later on, 1-2 years later, you switch to contact lenses. You never know. So the good thing is, whatever the child needs, you can do it then. So that's very important. It's not a one-way story. So if you choose atropine for this child, that doesn't mean that you will get 10 years or 12 years of atropine therapy at the end. So in my opinion, it will change anyway. So it doesn't matter what you start. It is important that you start with the thing that is the right therapy for this child at this moment and stage and progression. And then you always can choose another option that you have. And this is really, that's fantastic to have.
Mm-hmm. Thank you very much. There's one more question for now. Is your myopia management eye examination more expensive than the regular one? And if so, how do parents react on this, and how do you explain the need for more in-depth investigation?
Yes, so we are a little bit special. So if you have a first appointment in our practice, as I already said, we want to have all the baseline measurements in all the instruments. So we don't have something like only refraction for a child for let's say 60 euros or whatever. We don't have that. In fact, it's a little bit cheaper compared to an adult person coming to our practice the first time. So the child is paying a little bit less because the OCT doesn't make sense at the moment to do it like that, because you don't have the data to measure the nerve fiber layers and all the other stuff. So that's not really a problem, but of course, I mean, you need to be paid out of that. And in our, but that's perhaps just for Switzerland, I don't know. But if you explain to parents how important it is to have good measurements and that this will lead you in the therapy finding, there's nobody so far saying, whoa, that's too expensive. I mean, if you compare the costs for making your teeth, it's nothing in compared to that. So I don't know, perhaps it's different in Germany, I don't know, but as so far we didn't have that any problem with prices.
We can talk, of course, clear. I mean, it's cost between 800 and 1,000 Swiss francs per year for the parents to do this. And this is amount of money that in Switzerland is well accepted at the moment. So far, I have never seen or heard of parents and a patient of us that was not willing to pay this price. But they're getting a lot of service. They are getting a lot of contact lenses for this money, and therefore they see what they get. And so far, let's say below 1,000 Swiss francs per year, that sounds okay for them.
Mm-hmm. Thank you very much. In the meantime, there was another question. It seems like the biggest efficacy comes during the first year and then it flattens. Do you ever change treatment after 1 to 1.5 years, even though there is a stable progression, to see, for example, if it's possible to boost the efficacy of another treatment for the next year? So do you do something like that, or?
So you change the treatment every year because you want this extra boost of the first year.
Yes.
No, personally, I never made it like this. I change when I see that it's not in the expected curve, in the expected progression. Then I have to think about, is my therapy the correct therapy? But just to change every year, just to have this extra boost. So far, I never did it. I don't know, Michael, you did that? No,
No,
I don't think
no.
so.
No, I think it's also very difficult to explain to the parents why you change something if it works. So if you have all the nice charts here on the software, you are on the line, you discussed before, it should be okay. And now you're saying, well, perhaps it need another boost. Difficult. But well, I don't know. Perhaps in 2 years we do it. I don't know.
It's interesting, isn't it the other way around? That sometimes you have the potential perfect treatment, and then the patient or the kid comes up and say, "Look, I don't want to wear contact lenses anymore," or the other way around.
Yeah.
Yeah.
It's probably more than that. Yeah. So you
Yes.
have, I don't know what happens to anybody in the life. So sometimes some environment is changing, or the parents have some problems, and that's just reflected to the child, and you get that feedback. The child don't want to wear contact lens anymore. I don't know, but I mean, again, we have so many different things like the DIMS glasses now. You can change, but it should be, if it's your judgment to say we have to change something, you should have some evidence-based background why you're choosing this treatment now. Why is it important to do something different? If it's not enough efficacy, it's absolutely okay to change a treatment. But if you don't have anything like that, yeah, I don't think stay on the good thing if it's good.
Mm-hmm. Perfect. So I don't see any more questions for now. I would like to say thank you to both of you, Dr. Michael Bärtschi and Michael Wyss. Thank you very much for this wonderful talk and answering all our questions.
Thank you.
Thank you very much.
Great.
Thank you once more, and also to the audience. I just want to mention quickly, we have another webinar coming up on the 27th, so in 2 days, about Hill RBF 3.0. So if you're interested, feel free to join. I would happy if you do so. And with this, thank you everyone and have a wonderful evening.